Good evening. This is Dr. Lewis Foley, one of the Exam Pro faculty, and we are going to go ahead and get started with our World Board Prep webinar for Tuesday, August 10th, 2021. Tonight we're going to be doing caseless defense, and before I get started with that, I just want to go through a couple of reminders. First of all, this is an older version of the control panel, but the controls are similar, so I will just take you through this. The little orange box with a white arrow allows you to collapse or expand the control panel so that you can have it out of your view during the webinar. The upper portion is how you would participate in the audio mode. You, by default, will probably have your computer, microphone, and speakers assigned, but you can use a telephone by clicking Use Telephone just right here, and you'll be given a number to dial in, and very importantly, an audio PIN number that you must enter in order to be able to be unmuted and to sit in the hot seat. So again, if you're in a place with a lot of background noise and you want to use a telephone, that works quite well. We do not use the feature for typing in questions, so I won't know if you type in a question. If you want to participate in the webinar, we use the raise a hand feature. So I'll just have you click the raise a hand feature, which looks a little different than this hand, but it's the same idea. You click the raise a hand feature, I know that you are either volunteering or you have a question. I do want to mention that our webinar sessions are all recorded. If you have a need to access a recorded session, you can contact Exam Pro about the policies and procedures for that. And we are going to go ahead and get started. Now, this is my first caseless defense webinar for 2021. I do want to remind you guys of a few pieces of advice very, very briefly. First of all, practice like it's real. So as you go from here through until you go to Dallas, gradually work your way up to being able to do a 1-hour mock oral without feedback from your practice examiner or taking any breaks. If you can get consistently comfortable working in 1-hour sessions, you will be ready for Dallas. I do want to remind you that you are right now probably finalizing and submitting your case list. Once you submit a case list, please, please, please only work from a copy of the final list that you submitted to ABOG. This becomes even more important now that we use computer technology in the exam, because they're probably only going to show you one case at a time. So you want to get to know those cases well. And if what you're looking at looks even slightly different, you may not recognize the case when they put it up. So use the version that you submitted, because that's what you'll be using in the exam. Now, I do want to mention something. I think this is a very important concept. Your exam is really 3 separate exams, each 1 hour in length. Half of each hour, so 3 1-hour sessions, half of each of those 3 sessions is going to begin with your case list. It's going to be based on your case list. It doesn't mean it'll be everything on your case list, but the discussion will start there. So essentially, half of your exam is based on your case list. So once your list has been submitted, and until your list is submitted, the most important thing is prepping your list and getting it good. Once your list has been submitted, the next most important step is to get mock oral practice using that list. All right, so the last thing I'm going to say is this slide here. Know the major cases and trends on your list. For instance, if you have interesting or unusual diagnoses, it's important to know a little bit about these. If they ask you about something unusual on your list and you don't know anything about it, it will look a little bit less than ideal. Know the meaning of your pathology and is it consistent with your pre-op diagnosis. Complications, know the complications that you have on your list well. Cases that were managed in an atypical or unusual manner, maybe under a research protocol, you should know those cases well. And you should also be aware of high yield topics that are
Hi, I can't seem to hear anything, so I might have to, I don't know if I can go out and come back in. I'm going to try to do that.
Dr. Benda, can you hear me? If I'm trying to unmute you, if you can hear me.
Yes, I'm back. It works now.
Okay. Yeah, for some reason, did you get kicked off?
I didn't get kicked off, but all of a sudden, I think the slide prior, the audio just quit, and I tried touching fine, but
okay, I think I got
my usual trick of getting out and going back in, like I do with telehealth.
Okay,
works just fine.
I just did the same thing because the same thing happened to me. Okay, so I'll just go back to this. Let me just 1 second. I'm going to go back to this previous slide just for a second. So could you guys hear me when I was mentioning this right here about knowing your case list and the trends that are on it?
We had kind of started it, the interesting diagnosis. You need to know the complications. Otherwise,
so
super great.
I think everybody can read that. And the bottom line is that these are kind of the things that you really need to know on your case list well. So I'm going to go ahead and get into the mock oral part of this, which is what we're here for. So Dr. Benda, can I go to you first?
Absolutely.
Okay, so let me go. I'm going to close this presentation out so we can get to the case list. Which case list do you want me to go to?
Let's do office, if you don't mind.
All right. Any preference? I can pick anything I want.
So if there is a case that I'm interested in getting your feedback in and kind of trying out, it's under breast disease, benign and malignant. And it would be a 72-year-old G4P4.
Okay, let me find that here.
It might be on page 6 or so. Oh, wait, hold on, go. You know what? Did I move it? Hold on. It might be on the first. I might have moved this preventative care and health maintenance.
72-year-old G4P4?
Yeah, there she is. Okay.
Okay, so let me just see here. Okay, so this looks fairly straightforward. What is your question with the case?
Oh, I just wanted to go through it.
Okay, no problem at all.
Yeah.
So let me ask you this. The patient presented to you, you had been her doctor in the past, or she was a new patient?
No, this was a new patient to me. I believe she'd been seeing another physician out in the community.
And she was on hormone replacement therapy. Was she on estrogen and progesterone or just estrogen alone?
This patient was status post a hysterectomy distantly, and so she had been on estrogen for over 15 years alone, just ERT.
Okay, so tell me about that. Normally, and we'll get to her other issue here in just a second, but normally when you prescribe estrogen replacement therapy for a patient, how do you approach the duration of therapy and what to do over time regarding the risk-benefit equation?
Absolutely. So estrogen or HRT, depending on the presence of uterus or not, are indicated as treatments for vasomotor symptoms. And so the kind of golden rule is to prescribe the lowest amount for the shortest duration possible. So while a patient who suddenly became menopausal may have hot flashes requiring a higher dose of estrogen in the beginning. As time goes on, in my practice, I do constantly reevaluate this with my patient and see if my patient feels ready to step down on therapy whenever I see her.
Okay. And do you have an age at which you tell patients that they should not be on hormone replacement therapy after that age?
I do not have a distinct cutoff. You will see people that I see 65 tossed around a lot. But, as we come to a less paternalistic model of medicine, I'm always counseling my patients whenever we're prescribing or refilling HRT or ERT about the risks and benefits of continuing or not continuing and starting to taper down. And if the patient accepts the risks associated with continuing to be on estrogen or progesterone at whatever dose she's at, that is a decision that she is able to make as a consenting adult.
Was this patient on oral estrogen, or was it being administered in some other way?
The patient was on transdermal estrogen.
Transdermal. And what are the benefits of transdermal versus other methods of administration?
Transdermal avoids the first pass route, so it is thought to have a lower risk of VTE than the oral formulation.
Does that change the risk for other complications like breast cancer at all, or just VTE?
Breast cancer, I'm not certain of. I mean, obviously, as far as the risk of breast cancer being on hormone replacement therapy in general, from the WHI study, I believe that the effect was neutral on breast cancer for estrogen alone.
Okay, now what about the diagnostic imaging here? You did the screening mammogram, it was abnormal, and then it says diagnostic ultrasound. So did they also do a diagnostic mammogram or just an ultrasound?
So this is all done through radiology. So she had a screening mammogram. She had, and then at that time of an abnormal finding on that screening mammogram, same day, I believe she had a diagnostic ultrasound, which also was concordant with the finding on mammogram. So I believe that it's, typically if the question is asking, what is a screening mammogram? A screening mammogram is for people who are asymptomatic. A diagnostic mammogram is for people who have some sort of symptom or some sort of finding on mammogram. Then presumably the order I put in was for a screening mammogram. And then she went on because there was an abnormal finding in that screening mammogram to have the extra views to make it diagnostic, and then had a diagnostic ultrasound that allowed them to then do the ultrasound guided core biopsy because it's visualized in ultrasound.
Okay, so tell me this, BIRAD 5, what does that mean?
BIRAD 5 is highly suspicious for malignancy.
Okay, and can you tell me the other BIRADS categories and what each of those mean?
So BIRADS 0 is something that needs additional imaging. 1 or 2 are considered essentially benign. 3 is kind of like a borderline, and then 4 and 5 are suspicious for malignancy, requiring further diagnostic follow-up.
Now, are there any subsets within number 4? Are you familiar with this?
I am not super familiar with that, but it is sounding slightly somewhat familiar.
Okay, and then are you familiar with number 6, BIRAD 6?
I'm not.
Okay, not a problem. Now, in this particular case, you took the patient off estrogen. Did you offer her any other therapy for her symptoms?
Yes. So, yes, I had offered her, what had we done? I had told her about the results, told her to stop the estrogen, told her we could discuss further options for management, like an SSRI, or et cetera, et cetera. She said she wanted to kind of take it as it is. And I followed up with her a couple of weeks later, and she said she was fine. She didn't want anything. I just kind of gave her a call and wanted to see how she was doing. And she said she didn't need anything right now. She was actually without any vasomotor symptoms whatsoever.
Okay, if she did want to try something else, you mentioned SSRIs. Is that what you would have recommended for her?
No, I should be more specific. So an SSRI or an SNRI, if she is, given that she has this picture of newly diagnosed breast cancer, to minimize her risks of, like a malignant hyperthermia or anything like that, I would recommend, I would start this patient if she wanted I would have started her an SNRI as opposed to an SSRI. So I would start her on venlafaxine if she had wanted to give that a go.
Why would you not start her on an SSRI?
I'm sorry, I had said malignant hyperthermia and I meant serotonin syndrome. So the SSRIs in conjunction with tamoxifen, if she was to be prescribed or if she was to receive tamoxifen, could lead to a serotonin syndrome.
Okay, all right. Besides SNRIs, what other non-hormonal medical treatments are potentially helpful for hot flashes?
Sure. So for prescription treatments, there is also clonidine, contraindicated in this patient because of her hormone-positive cancer would be progesterone at night. She could, however, be a candidate for gabapentin.
All right. And I'm just looking here. Everything else for this patient is pretty straightforward. Doesn't look like she has any other comorbid conditions. I think I'm going to stop here. So let me just give you a little bit of feedback. Some key points. Yes, with the Women's Health Initiative, estrogen alone was neutral regarding breast cancer. So I would agree with that. With the BIRAD system. So BIRAD 6 is actually just biopsy confirmed breast cancer. It's not really an imaging finding, but it is actually in the BIRAD system. BIRAD 4 is subdivided into A, B, and C, which A being the least likely to be cancer, and then B being majority of that. BIRAD's 4, I think it's like A is like less than 5%, and I may have the numbers not exactly right, but it's something like 5% or less, and then it goes to like 95% gradually through A, B, and C, and I don't remember the exact cutoffs. And then anything that is really felt to be cancer until proven otherwise would be BIRAD 5. And then 3 is likely benign, but warranting some follow-up, and then 1 and 2 are both felt to be benign. And then U0, as you mentioned, is incomplete. And that's a very brief summary of it, but they do actually have the entire table. The only reason I think it's relevant, because I really don't think it's that relevant, but the only reason I mention it is because they do have the entire BIRAD system laid out in a table in the practice bulletin on, I think it's in the benign breast disease practice bulletin. So a couple of other things that we talked about here. Absolutely, when we think about patients with breast cancer on tamoxifen, we do not want to give them an SSRI. We give them the SNRI, so that was a good point. The medical options, clonidine and gabapentin would be the other ones. I was trying to think if there's anything else that we talked about. I don't think so. I didn't ask you this question, but you got the ultrasound guided core biopsy. I'm imagining that's probably what the radiologist recommended. Would an FNA be an acceptable option? A fine needle aspiration?
That would not be an appropriate option here because that gives you histology and we need pathology in this case when working on pregnancy.
Yes, so the FNA gives you cytology, like a pap smear. Yep, okay. And the core biopsy gives you histology, which is a clump of cells and the relationship to each other, and that's what we want. So yeah, okay. I think I'm going to stop there. Any questions from you before I let you out of the hot seat?
So with this, strategically in my list, I had put this patient, as I mentioned, under like the breast category. But then I was like, for preventative health, I could use someone who's a little bit of a different age than my other 32-year-old that I've had for preventative.
I can't hear you. You're still there?
Oh, yeah.
You're kind of faded out. I heard you say you had it in one category and then you moved it to preventative health and then it faded out. Sorry.
Okay. Can you hear me now?
Yes, I can.
Okay, perfect. So I was trying to add breadth to my preventative care and health maintenance category by having an older patient as well as a patient who is in her 30s. But it seems like no one would ask me about preventative health maintenance for this patient because she has a cancer. Would that be a correct statement to make?
I think that is highly variable. So I think it's a good strategy to have an older patient on here. And I think that that idea that if you have two patients in the preventative category, having one older and one younger, that is definitely something I do recommend. The question here, you laid this case out pretty clearly on paper. So, I could completely imagine if they wanted to talk about, I don't know if you have geriatric patients on your list, if you have other older patients, but if this is really one of the few older patients on your list, then I could completely imagine that they might decide to talk about preventative care. In particular, I'll give you an example. Sometimes there might be a structured case, for instance, that deals with a breast cancer kind of scenario or breast lump kind of scenario. So they might choose not to ask you about this part of this case because they've already covered it in the structured cases during the first 30 minutes of your hour, okay? So this is the wild card that we don't always know. They don't know what the structured cases are generally going to be until that morning when they show up to give you your exam. And so the examiners, they're going to give 3 exams in the morning and 3 in the afternoon, and the structured cases are going to be different in the afternoon than they are in the morning, and they don't get prior knowledge. So they're basically prepping multiple different avenues of questioning, and then if something shows up in a structured case, they'll just say, oh, we're not going to go there. Does that make sense?
Yeah. Okay. So, I have another patient that I could put in that is literally going to be like 65, well-woman visit, age-appropriate screening, and that's it. Is there merit in doing that? Because I wouldn't be hitting my 40 cases.
No, I don't think you need to. So you would get
70s already.
I'm assuming you would get rid of this patient to put in the 55-year-old?
No, I would put this patient back in the breast section and then add another patient that's like 65 and otherwise uncomplicated for preventive.
Oh yeah, I think that's a great idea. Let me look at your breast section. If you only have one patient there, yeah, I would move this patient. Yeah, move this patient to the breast disease category and put that other patient in, because the more cases you can give, yeah, you have room. I would definitely do that. I would move this patient to the breast category, put that other patient in here, and then you really do set yourself up perhaps to be asked about older patients and age-appropriate preventative stuff. I think that's a great way to go.
Okay.
Okay.
Awesome. Thank you so much.
You're welcome. Nice job. All right, let me get other volunteers. If we have anybody else okay, I've got a couple, so I'm going to go to Dr. Herzlich next. Are you there, Dr. Herzlich?
Hi, I'm here.
All right, so let me get your case list. Do you have a preference which part of your list we look at?
I think we can do GYN.
All right, sounds good. Let me just pull it up. And is there any particular case, or can I look for whatever catches my eye?
Whatever comes.
Okay. I'll see what, we might talk about more than one thing, but I want to ask you about this case number 11.
Okay.
There's a 25-year-old G0P0.
Mm-hmm.
So were you pretty confident that this patient had teratomas preoperatively? And if so, why?
Well, this patient, I met her because she had complaints of pelvic pain, and under the physical exam, I noted that she had a mass, and under ultrasound, the report specifically said mature. They specifically said teratomas. So when
Okay. Why do you think the radiologist called it a teratoma? What would be some of the ultrasound findings that might suggest that?
So that would be so few of the characteristics will be cysts that are not simple in nature. There will be some heterogeneous content that may represent some fluid component, bones, hairs, which I eventually saw in the laparoscopy. So things that suggest of this kind of tissue under ultrasound will suggest this diagnosis.
Okay. Now, is it common for teratomas to be bilateral, like in this case?
Common. I think it's about 20 to 30% will be bilateral.
And when you counseled this patient regarding the surgery, were you optimistic that you'd be able to complete it laparoscopically, or did you counsel her that it might require converting to an open case?
Well, the cyst did not seems to be very large, so I thought I was pretty confident that I can complete it laparoscopically. Of course, when I counseled her, I said, like I do for any laparoscopy, that there is an option that I may need to convert to a laparotomy, but I told her that it's unlikely.
What was your most important priority when you were planning her surgery?
So of course, safety is first. She did not have any history of abdominal surgeries or pelvic surgeries, so I was not concerned of any adhesions or anything that will make the surgery difficult. The main concern will be to remove the cyst as complete as possible without rupturing it. And I used the endo bag in order to contain the cyst. So there was no spill during the surgery.
Okay.
Other
Now,
minor benefit will be faster recovery and better cosmetic, but these are really just minor benefit compared to the safety of the procedure.
so tell me, regarding mature cystic teratomas, what are they?
So it's benign tumor that is originate from the ectoderm, and usually it will contain multiple types of tissue, such as some gelatinic content, hairs, maybe some component of bones. They may grow into size, they vary, and they can cause pain. Usually they are benign and would not convert into a malignant tumor.
Can they degenerate into a malignant tumor?
It's very unlikely.
If that were to happen, what type of malignancy would you anticipate?
The immature teratomas are from the neuroectoderm, so it's different tissue that they will originate from.
Yes, I wasn't suggesting an immature teratoma. I agree with you. That would be something different. But can a mature cystic teratoma ever develop a malignant component? And if so, what type of malignancy would you expect?
They rarely can convert. I'm not sure into which type of malignancy they will convert.
Okay. Now, you mentioned ectoderm. Is that the only embryologic tissue type that's found in mature cystic teratomas?
I believe yes.
Okay. So let me go back and give you some feedback about kind of what I'm thinking during these questions. So first of all, with teratomas on imaging, they're often relatively characteristic, including often hyperechoic nodules within the mass. And this can be a fairly strong indicator of a teratoma. They can have a fluid to fluid level. They can have calcifications, and the Doppler is usually not going to show Doppler flow, okay? So the other things that I told you we were talking about here, bilaterality, I generally think about 15 to 20%. I think you were in the ballpark, maybe a little bit higher than that, but not way out of bounds, so that's totally reasonable. I asked you about what would be your most significant or most important priority in this procedure. And what I was really getting at here is that this is a 25-year-old G0, P0. So ideally, we would like to preserve her reproductive function. And so we really want to preserve both ovaries if we can. And at a minimum, we definitely want to preserve one. In my mind, the second priority would be making sure we remove the teratoma in total. Why is that important? What happens if we don't remove the whole thing?
It will just recur.
Yeah, exactly. And that happens not infrequently, where a patient will have a suboptimal resection and they'll come back and they'll have a recurrent teratoma and have to have repeat surgery. So there's a very fine line here between we want to remove the entire teratoma, but we want to preserve some functional ovarian tissue, preferably on both sides, because she's a 25-year-old G0 and she needs it for both reproductive potential and also for hormonal production for a normal, healthy life. So those are the important priorities there. And so, for instance, if you were struggling laparoscopically based upon either size or difficulty getting complete excision, then it would be better to convert to an open procedure than it would to be to remove her ovaries. And I think that is common sense. You kind of weren't even really going there because this wasn't that difficult of a case, but you understand what I'm talking about, correct?
Mm-hmm. Yeah.
Okay, a couple of other things. Mature cystic teratomas are benign germ cell tumors. That's how I would characterize them. They do contain embryologic tissue that is from the ectoderm, also from the mesoderm and the endoderm. So all three types of embryologic tissue are found in mature cystic teratomas. And they are very unlikely to become malignant. But if they do, the most common type of malignancy would be a squamous cell carcinoma. Okay, but that is rare. And that's different from an immature teratoma, as you mentioned. But for mature cystic teratomas, if you get malignant degeneration, it would usually be a squamous cell carcinoma. So, any questions for me before I let you out of the hot seat?
No, thank you so much. That was really good.
Yeah, Yeah, you're welcome. The thing about this is not like a very exciting case. It looks so straightforward, but there's a lot of different ways that they can go. And I try, always to be thinking about, this is a very important case because of the patient's reproductive potential, being a 25-year-old G0, and because this is a fairly common gynecologic pathology that we see. So good job. I really like it. Okay.
Thank you.
You're welcome. I'm going to mute you. I'm going to bring the next person up. I know that we had Dr. Lanasa, and we will keep going after that. Dr. Lanasa, are you there?
Yeah, can you hear me?
Yes, I can. Did I say your name correctly?
You did.
Okay, I'm always afraid I'm mispronouncing people's names. All right, so which part of your case list would you like to work from?
Oh, you can surprise me, and I can't think of a specific one right now.
Okay, I'll tell you what. Let's go to OB since we haven't done OB tonight. Okay.
Sounds good.
All right. All right, I'll tell you what. Let's talk about case 32 for a second. So in this case, you did a vacuum-assisted vaginal delivery.
Correct.
So do you do forceps deliveries also, or do you prefer vacuum?
I don't do forceps. I prefer vacuum.
Okay, so tell me about the vacuum. First of all, tell me about how you apply the vacuum to use it to assist with delivery.
I first confirm the position of the fetal head to typically like to make sure that the baby is in an OA position. I find the posterior occiput and place the vacuum device about 3 centimeters anterior to the posterior fontanelle. I think I said occiput first, but I meant you find the posterior fontanelle, place it 3 centimeters in front of it. I ensure, before placing that, I am making sure that the patient is consented, that she has proper anesthesia, and the baby is, in this particular case, the baby was about +5 station, but there were no maternal tissue around the area where I applied the vacuum. And so I place it on and I increase the pressure on the vacuum device.
Okay, now do you increase the pressure immediately upon placing it?
I do.
Okay, and then how high do you put the pressure?
I know that on this device, there is an area of red and an area of green, so that I increase it until the area of green, but I do not know the exact, I think it's millimeters of mercury.
Okay, and so once you have the pressure increased, then what do you do?
And then during this time, I'm telling the patient to not push while I'm applying it. And then once I have it applied, I ask the patient to bear down and push. And I pull at a 45-degree angle, and typically like to place my hand on the cup just for a little counter traction and pull while she is pushing at the same time.
Did you cut an episiotomy?
I did not.
Okay. What type of complications do you aware of that can occur with the vacuum?
Well, the fetal complications could be a cephalohematoma, retinal hemorrhage, bruising, potentially, oh my gosh, the easiest one I'm blanking, hyperbilirubinemia, and a subgaleal hemorrhage.
Okay. What's the difference between a subgaleal hemorrhage and a cephalohematoma?
A cephalohematoma is above the dura, and a subgaleal hemorrhage is below it.
Okay, so a subgaleal hemorrhage is inside the skull?
I believe so.
Which one is likely to have a larger volume of bleeding?
The cephalohematoma, because there's more room for the blood to expand.
Okay. Now, tell me how you repaired the 4th degree.
I repaired the external and internal anal sphincter with a finger in the rectum to ensure that I was not placing any sutures into the actual rectum. And then I grabbed, oh boy, this is tough to describe because I haven't gone through it yet. I grabbed the perineal muscles and repaired above the sphincter in the usual 3rd degree fashion where you approximate the transversus perineae and incorporate, you do it. I can't describe
Okay,
this.
I got it. Yep, no problem at all. Something to look at. Let me ask you this: what's the first step in repairing a 4th degree laceration?
Placing Alice's on.
Oh, yeah, I mean about suturing. What's the first structure you need to think about reapproximating?
The anal sphincter.
Okay, tell me what's the difference between a 3rd degree and a 4th degree?
The degree of the sphincter involvement. Well, the sphincter involvement.
Okay, so this is something I definitely want you to look at, because when you talk about a 4th degree, it tells me that the rectal mucosa has been breached. Okay, so the first step would be to reapproximate the rectal mucosa.
Okay.
Okay, so that definitely look at this, because this, if they're going to ask you about one, they're going to ask you about this one, the 4th degree. Okay, all right, but let's go back for a second. I like the description of how you applied the cup on the vacuum. Do look at your device. Usually I'm thinking the pressure is going to be about 500 millimeters of mercury in the green zone. So just take a look at that on your device. And then having the mom push while you apply gentle traction is the key. There are a number of different complications that can occur. This is a common question, the cephalohematoma versus the subgaleal hemorrhage. And a lot of times we get it confused. We don't see these very often, thank God. But the cephalohematoma, and I'll tell you before I tell you this, the best place I've ever found this, if you search this on UpToDate, it's like neonatal scalp injuries or complications of vacuum delivery, you'll find a little diagram that shows the different layers of the fetal skull and scalp, okay? And it shows where different type of bleeding complications can occur. The key point here, cephalohematoma, both these cephalohematoma and subgaleal hemorrhage are outside the skull. Cephalohematoma is under the periosteum of the skull. So it's external to the brain, external to the skull, but under the periosteum. So it can't cross suture lines because it's confined to the periosteum of the bone where it occurs, okay? So with that in mind, cephalohematomas have some limitation on how much they can expand. Subgaleal hemorrhage is the very next layer outside of that. So again, outside the skull. It's bleeding under the galea aponeurotica, which is the scalp, the fascia of the scalp, okay? So it can cross suture lines, and there's a larger volume potentially that can accumulate in that space. So it's actually the one that would be associated with a larger potential volume of hemorrhage, okay?
Yeah, I'm backwards,
yeah, no, it's fine. If you find that diagram that I'm talking about, and I've looked at a lot of different ones over the years, but that one that they have in UpToDate is the best one I've ever seen. It shows all the different layers. Now, you mentioned retinal hemorrhage, and I want to follow up with a question about that. So when retinal hemorrhages are noticed by the pediatric team after a vacuum delivery, is that an indication that something went wrong with the vacuum delivery?
I think it's on their differential for sure, but I'm sure there's a bunch of other causes for that.
Yeah, in fact, retinal hemorrhages are noted in a small proportion of uncomplicated vaginal delivery. So retinal hemorrhages are, we think of them as, oh, that must be really severe, but actually, in many cases, they occur spontaneously without anything having been done. So they're not quite as concerning as some of these other ones. And of course, generally speaking, the deeper the bleeding is in the brain, the greater the risk for consequences because of potential compression on the brain itself. So let's see, I'm trying to think if there's anything else I was going to tell you about this. I think I like the way you described about where you place the vacuum cup. That was great. You did mention a couple of the prerequisites, consenting the patient. I think you said making sure they had adequate analgesia, and of course knowing the station of the baby. You did a good job describing that. So there's a list of things you can think about. Like another thing you could consider, if the patient's been pushing for a while, you could drain the bladder again, just in case the bladder's filled up a little bit. I asked about episiotomy. Do you cut episiotomies very often?
I try not to.
Good, and that's kind of, I think, where we're at in today's practice, is that we generally are less enthusiastic about cutting episiotomies. And you know, obviously in this case, it potentially can be the beginning of an extension. And as you can see here, we didn't even need that. We already had a pretty significant laceration. So episiotomy, when it gives you room to do what you need to do, it can be completely reasonable, but just routinely cutting them for an operative vaginal delivery is not necessary. I'm going to stop there. Do you have any questions for me before I let you out of the hot seat?
No, it's just amazing how nervous you get. Thank you, though.
Oh, you know, yeah, that's the thing, and that's why you just got to practice, practice, practice. And the nice thing is, you know, if you can get a couple of people that you know to ask you questions, the more different people that you do this with, the more different questions you'll get. I'll tell you, don't count necessarily on the feedback that when you just ask a friend or a colleague to give you feedback, because sometimes, so the questions that people give you are great. The feedback sometimes can have some bias in it depending upon how academic they are in their practice. And so this is one thing I'm always very careful telling the candidates about. The examiners are going to generally be kind of the ivory tower, teaching hospital, academic mindset. And so if you're out in a community practice or, you know, very successful private practice, sometimes your partners or your colleagues may be doing things that deviate a little bit from the most academic minded approach, and you want to be careful about that. But when you get feedback from people, if it doesn't fit with what you were thinking, go look it up. I don't care if it's me. If I give you feedback and you're like, oh, I don't think that's right, go look it up, okay? Because in the exam, if you are asked the same question and you start to answer it and you're not confident of where the information came from, then it will show. You will start to, you know, waffle a little bit or seem uncertain, and that's not helpful. So again, keep practicing. Being in the hot seat, it's tough. Okay? All right, I'm going to let you out of the hot seat, and I'm going to go to Dr. Pham, because I think you were the next person I saw with your hand up. Dr. Pham, if you can unmute, I'm going to go back to the case list here. And do you have a preference which list we look at?
Yes, my OB list.
All right. Any particular case?
Yeah, case number 37, the last one, it's a bit of a doozy.
Okay, let me look at it here for a second. Oh, okay, yes. All right. Just a second. Okay. So the baby did fine, correct?
Yes,
Did mom live?
yes.
Okay. I'm going to ask you the most obvious question first. What do you think was the cause of her cardiac arrest?
Well, there could be a lot of causes. well, a couple causes. Potentially an amniotic fluid embolism. However, patients who like bleed out a lot, and she did have a postpartum hemorrhage, can have cardiac arrest from that. She also did have an intra-amniotic infection, which could have potentially have progressed to sepsis and caused cardiac arrest as well.
Okay, now, so when you were managing her case, at what point did things start to go wrong? Was she really sick prior to the delivery, or did everything seem to kind of go wrong at the time of the delivery?
Everything just kind of went south as the uterine incision was being closed.
Okay, and so take me through what you did first. It looks like, I'm assuming that what you noticed first was that the bleeding. Is that correct?
I guess to start off with, she did have a couple risk factors for postpartum hemorrhage. So she had a prolonged induction of labor course, or a long induction of labor course. She also had an intra-amniotic infection going into the C-section. And then after baby was delivered, she started to have kind of like hemodynamic instability. Like first, the anesthesiologist said that she was going into SVT as we were closing the uterine incision, and she did have like, and then at that point, you know, we also noticed that she had pretty significant uterine atony that wasn't firming up with uterotonic agents. And then soon after that, she went into cardiac arrest, and intraoperative chest compressions were done. And then ultimately, like her uterus wouldn't firm up with all the uterotonic agents, TXA. A B Lynch suture was done, but still like her uterus was just super atonic. And then eventually a C-hyst or a hysterectomy was done. And as we were kind of finishing up with the hysterectomy, she started oozing, like it looked like, clinically looked like she was developing DIC.
Now, had you already been administering a massive transfusion protocol at that point, or is that when you started it?
No, so at the time where her uterus was very atonic, we started giving her 2 units of blood, and then started calling for more blood and activated the massive transfusion protocol.
Okay, in your hospital, when you activate the massive transfusion protocol, what are you giving the patient?
It's 1-to-1-to-1 of packed red blood cells, FFP, and platelets.
Okay, if the patient's going into DIC, which of those is probably going to be the most immediate at helping to reverse her DIC?
Her platelets?
Okay, what is the cause of DIC?
It's where you're like consuming, like you're clotting and you're consuming all of those clotting factors, and then you're ultimately unable to clot because those clotting factors are being used up, and then as a result there's bleeding associated.
Okay, and so what clotting factors are you thinking about are most important here?
Factor 7. Sorry, this.
Okay, no, it's no problem at all. So we'll come back to that in just a second. So in your massive transfusion protocol, you're giving 1-to-1-to-1 red cell transfusion, FFP, and platelets. And this was started before the patient really started to decompensate and show evidence of DIC.
So here's the thing. Massive transfusion protocol was called for. However, it wasn't like the patient didn't start getting these products until after the DIC was seen. There was a little bit of a delay in kind of getting everything.
Okay, got it. Okay, got it. Okay. So let's continue on. Let me ask you a couple of other questions here. So when the patient went into cardiac arrest, that was after the fetus had been delivered.
Yes.
Okay. And you mentioned amniotic fluid embolus. What can you tell me about amniotic fluid embolus?
It's typically characterized by a triad of cardiopulmonary, like instability or hypotension, coagulopathy, coagulopathy and DIC. Am I sorry?
Okay. Yeah. So the things we think about, the patient, of course, is pregnant or recently pregnant, and they have cardiovascular collapse, respiratory difficulty and hypoxia can be associated. They can have seizures, and often DIC follows. So these would be kind of the things that we'd be thinking about there. Now, what is the hypothesis about what causes amniotic fluid embolism? I think it's kind of obvious from the name, but we're thinking that.
So there's kind of a interface between the amniotic fluid into the maternal system, and then that kind of causes this like anaphylactic or like inflammatory response that leads to that cascade.
Good. And there are some criteria that have been described for diagnosing amniotic fluid embolus. Do you know what those criteria are?
Like hypotension or a cardiopulmonary event. There's also the absence of fever as a part of the diagnosis. The patient, it's during labor or I think within 30 minutes of placental delivery. And then coagulopathy or DIC is a part of the criteria as well.
Perfect. Those are the four things that I'd be thinking about. Sudden onset of cardiorespiratory arrest or hypotension. Then you said absence of fever, absolutely, within 30 minutes of delivery or during labor, and then DIC. Perfect. So how do you prove that a patient had DIC?
There are no labs that you can do to prove. Sorry, did you say labs to prove DIC or amniotic?
Yeah, yeah. No, amniotic fluid embolus. Yeah.
Okay, there are no labs to prove an amniotic fluid embolism. It's kind of a clinical diagnosis. I believe there is like a lung stain that you can do, but that's post-mortem.
Okay. Are there any known risk factors?
Not really, because these cases are pretty rare.
And I would agree with everything you just said. There are no, it's a clinical diagnosis. There are no known reliable risk factors. And I want to go back for a second and talk about the massive transfusion protocol and DIC. So because I think what we just talked about for AFE, that's everything that I would have asked you about this, okay? And you were all over that. With the massive transfusion protocol and DIC, so with DIC, I think of this as another way of describing it, a consumptive coagulopathy. So basically, I think you mentioned this, the patient's using up clotting factors, and the two that I think being most important as far as resuscitating the patient would be a combination of the platelets and the fibrinogen, okay? So FFP is where we're going to get the fibrinogen. It's going to also include other clotting factors, but FFP is going to be the fibrinogen component, and then of course the platelet transfusion. From a standpoint of reversing DIC or preventing DIC, those are really the two things we're going to be working on, because those are going to be the things that are going to be getting used up in this consumptive coagulopathy. Now, with the massive transfusion protocol, the idea here is to be proactive and liberal enough with our transfusion of products, not just blood, so that we don't get to DIC, okay? And so there are different criteria that can be used to initiate a massive transfusion protocol. Do you know what the criteria are in your facility?
If someone's going to need more than like 4 units of blood, then that's initiated. Also, if there's concern for bleeding more than 1.5 liters.
Okay, now, and usually the other component is that they're still bleeding.
Yes.
So, okay, good. That's an important point, because if their bleeding has been stopped, then and they're not in DIC already, then they may be able to get by with just a transfusion. But there's usually the criteria involves some kind of clinical volume issue. 4 units is a common one, and ongoing active bleeding. Okay. And there are a lot of other criteria that different institutions will use, but the simpler it is, the better off you are, because the key here again is to try to prevent getting into DIC. Now, I'm just looking at this case. I'm trying to see what else in this case. So it looks like the bleeding was not controlled with conservative measures, including B-Lynch suture. What else did you do besides the B-Lynch suture?
So in terms of medications, she got Pitocin, Hemabate, Methergen. Her preeclampsia was diagnosed postpartum, so that's why we also use the Methergen. And then, sorry, I said Pitocin, Hemabate, Methergen, and TXA. We tried uterine massage, and her uterus didn't firm up. And then a B-Lynch suture was done as well.
Okay, tell me about TXA.
Tranexamic acid, I typically give it when it's an anti-fibrinolytic, and I typically give it when there's concern for bleeding more than 1,000 mLs.
Okay, and has it been shown to reduce risk from hemorrhage?
Yes.
Is there a time frame in which it should be given related to delivery?
I believe it's within 3 hours.
Are you sure, or are you guessing?
I think it's anywhere from 1 to 3. So
okay,
that's my.
So you're correct. You're correct. So the tranexamic acid has been shown to reduce the risk of maternal mortality from obstetric hemorrhage if given within 3 hours of delivery. So the reason I mention this is sometimes it's like the last thing people give after they've given all of their uterotonics and they're kind of getting a little bit more desperate, but we shouldn't really think of it that way. It can be given, if my first uterotonic doesn't work, I'm thinking about adding TXA to the list. And certainly it's one of the things, again, if you think about AFE, they would, this would be something good to give. If you think about DIC, this could potentially be something good to give. But tranexamic acid early on, if there's an obstetric hemorrhage, definitely mention giving that, okay?
Okay.
So I think I'm gonna stop here. There's a lot of different ways this can go. And I think the most important thing I would tell you, as far as from what we talked about today, definitely look at the blood components that you give and know what's in each. So for instance, a packed red cell, the approximate volume of 1 unit, compare that to whole blood. What's the approximate volume of a unit of whole blood? FFP, what factors are in it? What's the approximate volume of FFP, 1 unit of FFP? Compare that to cryoprecipate. That's often the comparison they'll ask you about. So what factors are in cryo? What factors are in FFP? Which one has more fibrinogen? That's a trick question if any of you get asked that question. The actual amount of fibrinogen is similar in 1 unit of FFP and 1 unit of cryo, but the cryoprecipitate is a much smaller volume. So the concentration of fibrinogen in cryoprecipitate is higher because it's a smaller volume, but the actual amount is really similar between each of those. And then with platelets, the questions I'd anticipate, you might be asked about the difference between a 6-pack of platelets and a unit of apheresis platelets. Do you know the difference between those two?
I do not.
So they have an approximately similar amount of platelets, but a 6-pack is the traditional way of pooled platelet donors, okay? So they get platelets from multiple different units of blood donation. They pool them together. That's why they call it a 6-pack. The apheresis platelets is the same amount of platelets, but all taken from a single donor. This is a different type of collection. The donor is on a donation circuit for an extended period of time. The platelets are siphoned off, and then the rest of their blood is given back to them. And this allows for patients that are getting frequent or multiple platelet transfusions, like cancer patients, to have fewer potential exposures to become sensitized from different donors. So apheresis platelets, again, it's the same volume, it's just all from one donor. Okay?
Okay.
All right, any questions for me before I let you out of the hot seat?
I guess the way, I know there's like a lot in this case going on, but I guess
Yes.
the way it's written, does it make sense kind of? Or do you, like, would you make any suggestions about the way it's written, I guess?
Yeah, so the one thing I would say, if I was, and since you haven't submitted this, you have time, you can think about this. The one thing I would do differently is the treatment column, okay? The treatment column looks a little bit narrative. So for instance, what I like for the treatment column, in fact, I like the list in general to be bullet points. And so when I look at the treatment column, I'd be thinking induction of labor, then IV antibiotics, which was for the choreo. Then the indication for the C-section was I assume a persistent category 2 tracing, is that correct?
Yes.
So I would probably add to the treatment column before the CD, I would add something like intrauterine resuscitation, because I think you probably did that.
Okay.
And then on the next line, I would say primary CD, because this looks like what happened here. And then where it says with intraoperative hysterectomy and bilateral salpingectomy due to PPH, so this is becoming narrative. We're trying to tell the whole story on paper. So I don't think you went right to hysterectomy and bilateral salpingectomy. So those things, I would actually take all of that out where you say with intraoperative hysterectomy and bilateral salpingectomy due to PPH. You've got PPH over in the delivery complications column, so you don't need to restate it. So what I would do here is I would list your conservative measures. You could say uterotonics. On the next line, you could say tranexamic acid. On the next line, B-Lynch suture. By the way, I think you should capitalize Lynch when you say B-Lynch suture, okay? On the next line, you have to figure out, when did the chest compressions happen, before the hysterectomy or after?
Before.
Okay, so the next line would be intraoperative chest compressions and maternal intubation. And then when did you activate the massive transfusion protocol, before the hysterectomy or after?
I guess simultaneously.
Okay, so then what
before.
you could, yeah, so what I would do is say massive transfusion protocol, and then on the next line say hysterectomy and bilateral salpingectomy. Okay, you're just going to say it as a procedure, as a treatment. You're not going to describe it as a sentence. You're just going to say hysterectomy and bilateral salpingectomy. And you could say, was it a total or supracervical?
Supracervical.
So I would say supracervical hysterectomy and bilateral salpingectomy.
Okay.
Now what you've done, when you read down that treatment column, you can kind of see the whole case developing. Does that make sense?
Yeah.
And if they're looking for why did you do something in the treatment column, they look to the delivery complications column. Oh, category 2 tracing. That's why the intrauterine resuscitation. That's why the cesarean delivery. And the maternal cardiac arrest. That's why the chest compressions. That's why the intubation. And then you can see as you kind of go down. So that's the best way to handle it. And then what they'll do is they might decide to ask you about specific parts of it. Okay. And you're not stuck with this kind of convoluted story that you tried to tell in the treatment column. That's the biggest change I'd make. And if you do that, I think it'll be completely clear.
Okay. And then one last question in terms of when you asked, what do you think this is from? Or what her cardiac arrest is from? Would you tweak that answer?
So I'm going to tell you, when I look at this case, it's impossible to prove yes or no on an AFE or an amniotic fluid embolus. My suspicion, and this is just, you know, again, I'm totally giving you an opinion based on superficial evaluation of the case, okay? But my suspicion when I look at this case is that what got this patient in trouble was the hypovolemia, okay? And the consumptive coagulopathy that furthered that problem. And you kind of hinted at it when I started to really get into the nitty-gritty with you about the massive transfusion protocol. And you said, well, we wanted it to start sooner, but there was some delay. That's usually where these things go wrong. You know, can we say for sure it wasn't an amniotic fluid embolus? No, we can't. But amniotic fluid embolus are not very common. With the scenario you have here and the way it went along, it sounds like this is a more common scenario of hypovolemia, probably due to, and this is one of these things, we get in the moment and time doesn't really add up. You know, we spend a lot of time trying to do different things, not realizing how much time has gone by and not always appreciating how much blood has been lost. And then we try to play catch up, okay? And you know, we're very lucky that young women, they can tolerate a lot, but at some point they then will decompensate. And what happens is they kind of go from being, you know, pretty stable, like, you know, we weren't really too worried, and then all of a sudden they fall off the cliff, okay? And that's what this looks like to me. So when I asked that question, I kind of anticipated you would tell me that you thought it was probably the hemorrhage that led to this. I'm happy that you don't have amniotic fluid embolus on paper, because while it is in the differential, in my personal opinion, is that it may not be the true cause here. Okay.
Would you lead with the postpartum hemorrhage and hypovolemia cause then?
If they ask you what you think, if you look at what I'm saying and you agree with this, I think it is a reasonable thing as a presumptive diagnosis. Did you guys do any kind of discussion of this case among you and your colleagues after it happened?
Yes.
And so usually the thing I'd be looking at in that discussion is a timeline of how things went, kind of like we just sort of mapped out on the treatment column, and looking at the estimated blood loss for the case, what labs you had as the case developed, and then, you know, what the patient required to get her back to stability. And, you know, looking at it, I suspect it was probably a hypovolemia that contributed to this decompensation. That would be my guess. And the DIC, of course, which furthered that. Okay. But this is a case to do a little bit more research on. If there's anything about this case that you think, I don't really understand that, I'm not really following this, that's where you go do a little bit of research, because this is a case. If they don't ask you about this case in the OB section of the exam, I'll be surprised.
Yeah, I figured. All right. Thank you.
Yeah, you're welcome. All right, looking at time, we're a little bit over, and I apologize for those of you listening in if we kind of, the relevance here kind of for looking at a specific case, sometimes if you don't have anything like it on your list, it may not be as helpful, but I think this is a really great case. I am going to wrap it up for tonight because we have gone a little bit over. I do want to mention we will have a webinar tomorrow night, the 11th, which will be a structured case webinar. And we will be continuing, as you guys know, our webinars Sunday through Wednesday. So please join back in with us. And I'm going to end it here. So have a great night.